Hello, everyone, and welcome to another activity of our special series, Through the Looking Glass, Seeing a Better Future in Crohn's Disease. I'm Dr. Aline Charabaty, Associate Professor of Medicine at Johns Hopkins School of Medicine and the Medical Director of the Division of GI and Hepatology and Clinical Director of the IBD Center at Johns Hopkins Sibley Memorial Hospital in Washington, D.C., and of course, founder of Monday Night IBD. I'm joined today by my wonderful colleague, Dr. Robert Battat. He's an associate professor at the University of Montreal and the director of the Center for Clinical Excellence and Translational Research in Inflammatory Bowel Disease at the Centre Hospitalier de l'Université de Montréal. Rob, welcome, and thank you for giving me the opportunity to practice my French a little bit.
Thanks for having me, Aline.
Well, very excited about our activity today, but if you did not catch our earlier activities in this series on treat to target in IBD and IUS and other exciting improvement in our management of Crohn's disease, you can view them by visiting the Bonum CE website. All these Monday Night IBD activities are CME certified and jointly provided by PACE and Bonum CE. They are made possible with the support of an educational grant from Lilly. Our disclosures are shown on the screen. If you haven't done so, please complete our pre-activity survey by clicking the link below this video or by screening the QR code. Let us know who you are and make sure you complete your evaluation at the end of the session and claim your free CME credits. And of course, follow our handles at Monday Night IBD and Bonum CE and set your alert notification for more CME certified programs. Our learning objective for today is to evaluate the clinical efficacy and safety of newly approved and emerging anti-IL-23p19 therapies in Crohn's disease. So Rob, let's jump right into it. Before we start talking about IL-23p19, can you tell us briefly what is the difference between anti-IL-12/23p40, mainly ustekinumab, and the newer IL-23p19 therapies?
So both are monoclonal antibodies. The older version, such as ustekinumab, they bind the P40 subunit, which is common to both IL-12 and to IL-23, and inhibit them. The newer versions, the P19 inhibitors, bind solely to the P19 subunit, which is specific to IL-23. So these are really IL-23 specific monoclonal antibodies. And the idea behind it is that perhaps if IL-23 is more implicated in disease activity in IBD, that you may get a more potent inhibition of that pathway.
That's fascinating. So blocking two cytokines is not necessarily more effective than blocking the one that's more relevant to the inflammatory process. So we're living in an exciting time. We have a lot of different therapy and mechanism of action to treat our patient with Crohn's disease. Can you tell us, how you use IL-23p19 in your practice in your newly diagnosed bio-naive Crohn's patient? Let's start with that.
So we're using it a lot, and the idea is that this is a highly efficacious agent in both bio-naive and bio-exposed patients. Given the safety profile and the efficacy kind of across most Crohn's disease patients, I use it in most as the default. There are specific scenarios where I may even prefer it more so. So if the patient has psoriasis or psoriatic arthritis, because these are agents that are effective in that context. And then there are some scenarios where you may consider using another agent preferentially. So if you have fistulizing disease or axial spondyloarthropathies, those are scenarios where you may consider using some other agents, but for the vast majority, I'm actually using this as the default agent.
So I'm just going to push you a little bit more. So you have a
Sure.
bio-naive Crohn's patient. Guide us a little bit. How do you think about things in your practice? And of course, this is not extensive. There are
Yeah.
many things to take into account in terms of medical history, social history, and patient preference. But overall, when would you use an anti-TNF, a JAK, and other agents?
Yeah. So, the major considerations are disease severity. Not all moderate to severe Crohn's disease patients are the same. You have patients much more towards the moderate side, and some patients much more towards the severe end of the spectrum. And so I think the vast majority of patients fall kind of in the more moderate to severe as opposed to the severe spectrum. And those are the patients where I'm using IL-23s preferentially. In patients who are much more kind of in the extreme outliers of severity, those patients I'll consider using a TNF antagonist or a JAK inhibitor. Um, Again, depending on which country you're in, a JAK inhibitor may or may not be available to you in the bio-naive extreme patient. Um, and then you look at other considerations. So you look at extraintestinal manifestations. And I think that's a major consideration when you're thinking about TNF inhibitors and JAK inhibitors, which tend to treat many comorbid immune diseases. And so sometimes you can kill two birds with one stone with those agents. And then another major consideration is fistulizing disease. And I think that fistulizing disease, the best data currently are for anti-TNFs, and probably a second behind there is JAK inhibitors in terms of quality of data. Um, Although there are some observational data, for P19s and P40s, just the level of evidence is somewhat lower, but it's not an impossibility either.
Yeah, I think you and I practice in a very similar way in terms of choosing therapy based on disease severity, extraintestinal manifestation, perianal disease. And then when we're not in that situation where we're more in the moderate and without fistulizing, perforating disease and without extraintestinal manifestation, then we have the choices, right, between the IL-23, the anti-integrin, and isecuimab. And it
Yeah.
seems that the IL-23 is becoming a preferred choice in your practice. So switching gears, I think you and I see often patients who are already on the second, third, or fourth line of in advanced therapies. How do you think about IL-23 P19 in the context of a bio-exposed patient with Crohn's disease?
So I think the guiding principles are somewhat similar. Some patients, when they are failing a therapy, they kind of have persistent moderate disease despite the fact that they're, say, on an anti-TNF. Other patients are having a severe refractory disease, and I think those are different types of patients. So again, in the more extreme ends of severity, I tend to favor JAK inhibitors in the bio-exposed patients, but in the vast majority, which are generally not that, I tend to use the P19s in the bio-exposed patient, and the data are actually the strongest for this agent in this population. I also, again, look at extraintestinal manifestations and fistulizing disease in these patients. And so if you have, a refractory perianal fistulizing Crohn's disease patient, then I may favor, a JAK inhibitor over a P19, but otherwise, in the vast majority, I may not. There is another scenario that, I probably didn't mention for bio-naive, but definitely you see it a lot in bio-exposed patients is strictures. And patients with stricturing small bowel disease, obviously, there's a wide spectrum of these types of patients, but in a stricture that you feel can be treated medically, um, the you know I tend to actually use the P19s preferably, just in the context that there are some data with JAK inhibitors across the class for GI perforations and across indications as well. It's not to say that you cannot use a JAK inhibitor, but even in the trials, there were some small, again, the trials were not powered to detect this, but there were small, but numerical differences in GI perforations, even in Crohn's disease. So I tend to use P19s preferentially in those patients.
I agree. And I do tend to use B19 more often also for small bowel, isolated small bowel Crohn's disease. I believe, again, in the trial for Jack, we didn't see much benefit in treating small bowel disease. But again, these are small number. It's hard to draw a conclusion. But I tend to use anti-TNF or P19 for moderate to severe small bowel Crohn's. This is great. So we were talking about, how you use them and how you think about using them in bio-naive and bio-exposed. So maybe we can go over the data together. And one thing that is really striking across all IL-23 P19 that we have available or soon to be available is really the robust clinical remission in that we see in bio-exposed patient with Crohn's disease, very similar to the results with the bio-naive patients. So can you walk us through, maybe we'll start with mirikizumab and walk us through the clinical remission at the time of induction and maintenance and the endoscopic improvement that we see on this therapy?
So in the VIVID trials for mirikizumab in Crohn's disease, this was a treat through randomized control trial. So this means that, patients just either got one drug or placebo, and then they were treated through 52 weeks. And what you see is at the end of 12 weeks, you already start to see separation in the clinical remission rates between patients on mirikizumab and placebo. And then as you continue out to 1 year at week 52, you see further separation. In Crohn's disease, symptoms are one important component, but the major treatment target towards the end of 1 year is endoscopy. And really, you see a doubling of the endoscopic improvement rate for mirikizumab compared to placebo at the end of 1 year. So the endoscopic improvement rate was 46% for Miri and 23% for placebo. And in patients who with an endoscopic improvement at the end of 1 year, if you actually follow them out, there's a robustness and a durability of that endoscopic improvement to 2 years, where actually nearly 90% of those patients stayed in endoscopic improvement. So this is a drug that works well, and it works well across patients who are both bioexposed and bio-naive. The trial treated both, and both data showed very similar separations from placebo, with even a little bit more preferential delta at 1 year for clinical remission for the bioexposed population for Miri.
Yeah, I think this is very exciting data. And the one thing I like about this data is really the durability of the response, that patient who have been, who achieve endoscopic improvement at the end of 1 year on Miri continue to do so at year 2. We see this similarly also with other IL-23, P19, and we can go over the data for guselkumab and risankizumab together, where again, we're seeing robust response in bio-naive and bio-exposed patients. But in these trials, we're a little bit different than the Miri, is that the maintenance phase, 2 different doses of the drug were assessed for efficacy and clinical remission. So looking at the guselkumab data and the risankizumab data, mainly in the maintenance data, how do you interpret these results and how do you apply them to your clinical practice?
So obviously we're in a little bit of a data-free zone. We don't have a lot of evidence in terms of real-world use of separate doses for P19 IL-23 inhibitors. The data seem to suggest that if you have different doses, the efficacy in clinical trials is the same. Now, are there specific subgroups of patients that may benefit from higher doses? We tend to generally transfer those data from TNF antagonists, and I think when you have a patient in front of you who has some form of moderate persistent disease, we'll often try to maximize what we can get out of the drug to help that patient. And so I think many of us will try to dose escalate these patients currently, and that's our current practice. That being said, in the data may change that practice going forward. So we know that we did this for the P40 inhibitors for ustekinumab, and there were data that were just presented that showed that actually there is no benefit to doing this. And so I'm not sure if that's going to be a strategy that's going to be maintained long term. That being said, there may be some subpopulations of more severe disease with elevated SESCDs or elevated CalPROs that may preferentially benefit from getting a higher dose off the bat. And sometimes early treatment may alter outcomes in a different way.
I absolutely agree with you. And maybe one more category of patient where I think of using the higher dose are patients who have been exposed to more than one advanced therapy, or patients that kind of burn through therapies quickly, right? Really difficult to control disease. I agree. We want to give them the most chances to respond to this therapy. So before we wrap it up, can you review with us the safety data that we have with IL-23p19 therapies? What are the labs you check for when you're starting this therapy? What do you monitor? Any new safety signal we need to be concerned about? Or is this the usual, you approach it similar to what you approach other
So
biologics?
safety data is actually the easiest part about this because the safety data are very good. There were no new safety signals for this class than you would have seen for ustekinumab or even vedolizumab. And I think, initially when vedolizumab came out on the market, this was seen as the safe agent. And then ustekinumab came out, and it took some time for the data to play it out because of the MOA. But we see that ustekinumab was equally as safe as vedolizumab, and now we're seeing similar type of data with the P19 inhibitors. We also have the luxury of being the second indication for IBD as opposed to dermatologic diseases, and so we have also long-term data from another group of human beings who've been exposed to this drug in mass, and we see that the data, long-term data, is that it's a safe agent when given to humans. And so I don't have a lot of safety concerns with respect to this. I always tell my patients that, you know, there's no higher risk than placebo, and there is no black box warning, particularly for infection or malignancy. However, doesn't mean that you can't get an infection. It doesn't mean that you can't have something happen to you. But the question is it drug related? And I generally say it's likely not. And then in terms of what I do to follow up, just as precaution and maybe based on our practice patterns before we start the drug, I still do quantiferons. I still do hepatitis serologies. I'll, get a baseline CBC, chem panel, and then, I'll follow those patients generally just because this is our standard protocol. We'll do follow-up labs at, and calprotectin at baseline and CRP at baseline, and then we'll do that at follow-up every 3 months for a year, and then I actually space it out to every 6 months. Obviously, if a patient is not doing well, then we may keep up more close monitoring from there. And then I'll do a colonoscopy anywhere from 4 to 6 months post, depending on how severe their disease was from the get-go. So if if they're starting at very severe disease that you don't want to do a colonoscopy too early because you may miscategorize them as not responding. So I'll wait about 6 months to reassess at least.
That's wonderful. And I agree with you. I do give more time for more severe disease or patients who have been on prior advanced therapy. I feel often these are patients that maybe take a little bit longer to get better. And so it's important to give them that time and to reassess at an appropriate interval as opposed to too early and give up on the drug too early. So, Rob, thank you so much for this wonderful conversation and your insights into using IL-23p19 therapy and reviewing the data with us in Crohn's disease. So just to summarize the key discussion point today, IL-23p19 therapies are highly effective in both bio-naive and bio-exposed patients. They have shown a durable endoscopic response, which is very important. Like you pointed out, Rob, in Crohn's disease, we want to see clinical remission, but we also want to see endoscopic healing and persistence of that endoscopic healing, because this is what will ensure that the patient has the best outcome and decrease the risk of developing complication and surgical complication. So effective, durable response and high safety profile, no new safety signal, but of course, approach that similar to how you approach other biologic in terms of lab monitoring, assessment by endoscopy or fecal calprotectin in terms of assessing response, and of course, the preventive measures in terms of vaccination and skin cancer screening. So thank you again for everyone for joining us today. Please make sure you claim your free CME credit by completing the post-survey evaluation from the links below or by scanning the QR code. Rob, thank you again for joining us from Montreal.
Thanks so much, Aline.